Neurology Quiz number 85. Describe the pathogenesis, clinical features, and management of toxicity due to marine neurotoxins. The majority of marine toxins originate from unicellular algae. The proliferation of these algae depends on seasonal and environmental factors. During periods of high algal proliferation or blooms, high concentrations of toxins accumulate in fish or shellfish, which then serve as vectors for human disease. An example of such algal bloom in the United States is the red tide, which refers to reddish-brown discoloration of seawater. Most marine toxins are colorless, tasteless, and odorless, and often stable to heat, acid, and normal food preparation procedures, making them especially dangerous. This picture shows a red tide or algal bloom off the coast of Florida. Ciguatera fish poisoning. Algae that produce Ciguatera toxin are found in tropical and subtropical regions, mainly in the Indo-Pacific and Caribbean waters. Algae are consumed by fish such as sea bass, grouper, red snapper, and eel. Symptoms are typically dose-dependent, and most severe poisoning occurs after consuming the toxin-rich head, liver, and viscera of the contaminated fish. Clinical manifestations are caused by the toxins Ciguatoxin and Metotoxin. Ciguatoxins are lipid-soluble molecules that act on voltage-gated sodium channels in nerve and muscle, leading to increased sodium permeability and membrane depolarization at rest. Metotoxin is a water-soluble compound that increases calcium influx through voltage-independent sodium channels. This picture shows the type of fish that are a source of Ciguatoxin for humans, including snapper, grouper, and eel. GI symptoms include abdominal pain, vomiting, and diarrhea, which appear within a few hours and may be accompanied by bradycardia and hypotension. Subsequently, patients develop neurological symptoms with centrifugal spread of paresthesias involving the oral cavity, pharynx, limbs, trunk, and the genitalia and perineum. A characteristic feature is paradoxical temperature reversal. Cold is perceived as burning, tingling, or unbearably hot, and less frequently warm is perceived as cold. Other features include headache, fatigue, weakness, myalgias, metallic taste, as well as pruritus and arthralgias. Symptoms are worsened by alcohol and exercise. Patients can be mistaken for having psychiatric disease. Examination can reveal findings of mild sensory neuropathy. Most neurological symptoms resolve within a week, but some degree of pain, paresthesias, and headache and fatigue can persist for months to years. This figure shows the site and mode of action of ciguatoxins. In the motor and sensory neurons, ciguatoxins cause persistent activation of sodium channels and block potassium channels. This causes membrane depolarization and leads to spontaneous and repetitive action potential firing. Diagnosis based on history of ingestion, clinical presentation, and clustering of cases if present. Nerve conduction studies may show slowing of sensory and motor nerve conduction velocities. Ciguatoxin assay in fish is available. Treatment: gastric lavage can be done if the patient presents soon after ingestion. IV mannitol has been used for treatment and is thought to cause decrease in edema in the Schwann cells. Supportive care includes fluid replacement, treatment for symptomatic bradycardia, and treatment of headache, pain, and anxiety. Chronic symptoms of poisoning are difficult to treat and may require medications for neuropathic pain. Shellfish poisoning. This is most commonly associated with ingestion of mollusks such as clams, oysters, mussels, squid, or octopus. Outbreaks are common during the summer months. It is of three types. Paralytic shellfish poisoning. This is the most common and most severe shellfish intoxication. It occurs in the United States along the coast of New England, Pacific Northwest, and Alaska. Children are more susceptible. Clinical manifestations are caused by Saxitoxin, which is a heat-stable toxin acting on the peripheral nervous system and binds reversibly to voltage-gated sodium channels and calcium channels in nerve and muscle membrane, blocking impulse transmission. Symptoms appear 30 minutes to 3 hours after ingestion. Paresthesias are common and involve perioral areas, oral cavity, face, and neck, and then spread to the limbs and trunk. Weakness can occur and involves muscles of the face, jaw, swallowing, limbs, and respiratory muscles. Respiratory muscle involvement occurs 2 to 12 hours after ingestion and is the major cause of death. However, weakness is not universal. Brainstem symptoms and signs can occur and include ophthalmoplegia, dilated pupils, nystagmus, dysphagia, dysarthria, and dysphonia. GI symptoms are less common. Recovery usually begins in 12 to 24 hours and is complete within a few days. However, in some cases, weakness can persist for weeks. Mortality rates vary from 1 to 12%. Diagnosis is mainly by history and clinical features. An ELISA test is available for Saxitoxin. Nerve conduction studies may be abnormal. Treatment is supportive with particular attention to monitoring for respiratory insufficiency. Neurotoxic shellfish poisoning occurs primarily in the Gulf of Mexico, the Caribbean Sea, and waters around New Zealand. Clinical features are caused by brevetoxins, which cause depolarization of cell membranes and persistent activation and repetitive firing of nerves and muscles. There is simultaneous onset of GI and neurological symptoms within hours of ingestion. Clinical features include nausea, diarrhea, rectal burning, circumoral paresthesias, dizziness and ataxia, as well as myalgias. Dysphagia, pupillary abnormalities, tremor, and areflexia may occur. Neurological symptoms are milder than in the paralytic type, and mortality has not been reported. Treatment is primarily supportive. Amnestic shellfish poisoning. This involves the central nervous system. The toxin responsible is domoic acid, an excitatory neurotransmitter, and neurological features result from its excitotoxic action, especially on the limbic system. Symptoms occur within a few hours of ingestion, with nausea, vomiting, diarrhea, and headache. 25 to 30% of patients present with memory loss, disorientation, mutism, myoclonus, seizures, and coma. Gradual improvement occurs over 2 to 3 months. Residual deficits include anterograde amnesia. Some patients develop temporal lobe epilepsy. Treatment is symptomatic. Diazepam and phenobarbital seem to be most effective in controlling seizures. Pufferfish poisoning. These fish have a worldwide distribution in fresh and salt water, but are most commonly found in China and Japan. Fugu is a Japanese pufferfish delicacy, and if not prepared properly, can lead to severe poisoning. The responsible toxin is Tetrodotoxin, which selectively blocks voltage-gated sodium channels in excitable membranes and blocks impulse conduction in somatic and autonomic nerve fibers. It reduces excitability of skeletal and cardiac muscles and also has marked effects on vasomotor tone and central regulation of respiration. Concentration is highest in the viscera and relatively low in the muscles. The source of the toxin is thought to be marine bacteria that colonize the fish. This picture shows pufferfish that are a source of tetrodotoxin. Ingestion is followed by nausea, vomiting, and diarrhea. Lip, tongue, and distal limb paresthesias appear from a few minutes to 2 hours after ingestion. Ascending limb weakness occurs along with dysphagia, dysphonia, and hypoventilation. Bradycardia and hypotension develops in severe cases. Seizures and coma can occur. Fatality rates are high in severe cases due to involvement of the respiratory system and cardiac dysfunction. Diagnosis: liquid chromatography may detect toxin in the serum or urine. Nerve conduction studies may be abnormal. Treatment is supportive. Gastric lavage and charcoal should be instituted if patients present early. There are anecdotal reports of improvement with neostic mean. Patients who survive the first 24 hours often recover without neurological sequelae.